So today we'll be talking about cancer chemotherapy or cancer pharmacology. Now, cancer as such is a condition in which the body's normal cells are dividing uncontrollably. Okay, there is uncontrollable proliferation, which is mainly invasive and metastatic. Okay, it will metastasize from one place to the other, especially depending on the grade of cancer. It might originate from one place. Later on, in advanced stages of cancer, it will metastasize to other places and it will involve several other organs. Now, because cancer cells are your own cells, whenever you give a drug for cancer, it will not differentiate between normal cell and cancer cell, because technically speaking your cancer cells are normal cells which are continuously dividing. There is no stop mechanism to their division, right? If I have, let's suppose, liver cancer, if a patient has liver cancer, and hepatocytes are the site where division is occurring. So there is proliferation of hepatocyte to an extent where a proper tumor is being formed. Now, as such, if you cut open this tumor, you will be able to see that it is made up of hepatocytes. So whenever you give a drug that is trying to delete those tumor cells or trying to decrease or kill those tumor cells, you will invariably end up killing normal cells as well, because the drug will not differentiate between cancerous cells and normal cells. So wherever, let's suppose, I'm trying to treat liver cancer, I will end up decreasing normal liver function as well, because those cells will not only kill tumor cells, they will also kill normal cells. Now, because they are your normal cells which are proliferating, your immune system also will not work well against these tumor cells, because your immune system will register them as your own cells. All right. If someone has a tumor, a cancerous tumor, those cells which are made up of the same organ, or the tissue, the cellular lining of the same organ, your immune cells, your T cells, B cells, they will not recognize this as a what do you call, unknown material, as any what do you call, pathogenic material, because of which your immune system will not take part in killing this tumor cell. All right. Now, as such, there are several different types of cancers, but there are a few common cancers. I will list them out. So, first of all, there are over 100 to 100 different types of cancer. Okay, they can be broadly classified into the following types. First of all, we have sarcomas. Now, sarcomas are those cancers which are originating from connective tissue. So, bone, muscle, tendons, cartilage, fat, yeah, blood vessels, या फिर nerves, all of those are connective tissue. वहां पर पूरा even blood के लिए एक specific अलग category है, but technically that will also be a subtype of sarcoma. Now, anything that is originating from connective tissue will be a sarcoma. Connective tissue origin. All right. Then we have carcinomas. Carcinoma. Okay. Carcinoma are skin cancer. Specifically, these are cancers that are arriving or originating from epithelium, cell lining of different organs, tissue lining of different organs. वहां से start हो रहा है ये. It will also include melanoma, which is like pure skin cancer. Melanoma, basal cell carcinoma, or squamous cell carcinoma. All of them come under carcinomas. Then we have something called leukemia. Leukemia is proper blood cancer. So any type of blood cancer, whether it is originating from RBC, WBC, or any other part of the blood, and that will be included in leukemias. Okay. Then we have lymphoma. Lymphoma is the cancer of lymph. Okay, as the name suggests, cancer of lymph. Right. Then we have some special type of tumors like let's suppose glioma or ganglioma. Glioma and ganglioma. Now, glioma is tumors in your brain and spinal cord. Ganglioma is when ganglia are getting involved and they are having carcinomas. Then you will have other types of specialized cancers as well, like choriocarcinoma. Choriocarcinoma is when uterine lining of the patient gets affected. Okay, that is uterine cell cancer later on, which spreads to the placenta as well. ठीक है, उसको कोरियोकार्सिनोमा बोलते हैं. There is breast cancer, obviously, that is a type of carcinoma. ठीक है, especially ductal carcinomas, very very common. You have adenocarcinomas. Adenocarcinomas are those cancers that are originating from glandular structures. Okay, adenocarcinomas originate from glandular structures. Okay, so these are some of the common types of cancers. Now, as such, whenever you treat cancer, there are any cancer drugs, they will have some common adverse effects because they are killing normal cells. There are certain side effects that are very common with all types of anti-cancer medication. Okay, so common ADRs, we'll get into specific ADRs when we talk about drugs as well, but common adverse effects that are associated with anti-cancer therapy. ठीक है, इन लोगों को एंटी नियोप्लास्टिक्स भी बोलते हैं, एंटी कैंसर ड्रग्स को एंटी नियोप्लास्टिक्स भी बोलते हैं. फर्स्ट ऑफ ऑल यू विल हैव बोन मैरो डिप्रेशन. Bone marrow depression will be presented as leukopenia. ठीक है, the patient might have anemia, thrombocytopenia, meaning both WBC, RBC, and platelets, all of them will go down. The patient sometimes might have anaplastic anemia, especially aplastic anemia in very high doses of anti-cancer drugs. They will have aplastic anemia because there is bone marrow depression, infections, and bleeding. The chance of the patient having infection and the chance of bleeding occurring will also increase. ठीक है, WBCs कम कर दे रहे हैं and platelets कम कर दे रहे हैं, तो you are increasing the chances of the patient getting infections and increasing chances of bleeding. Then second common problem will be proliferating cells. ठीक है, other proliferating cells get affected. Specifically, what happens is it will cause inflammation in other areas. So, specifically in GIT, anti-cancer drugs can cause stomatitis and esophagitis. Okay, it will be very, very painful. Sometimes there will be diarrhea and ulcers. Ulcers are quite common actually. The patient might have alopecia, patchy baldness. Spermatogenesis will decrease, and amenorrhea will occur in women. Okay, so the total amount of sperms being formed will decrease, and menses will not occur properly in women. Then there are a few intermediate adverse effects as well. These will mainly include nausea and vomiting. Now, the case of nausea and vomiting in anti-cancer therapy is very very strong because most of the anti-cancer drugs are cytotoxic. They will cause cell death by one way or the other. They will cause cell death, because of which once you have given the treatment or once you have given the drug of cancer, within 4 to 6 hours the patient will start having nausea and vomiting, severe nausea and vomiting, and it will go on for 1 to 2 days. Now, cancer therapy or cancer treatment is done in cycles. If you have ever worked in a cancer ward, you'll know what eventually when you do enter a cancer ward at one point of time, you can see that the treatment is done in cycles. Those cycles, कैसा करते हैं? One cycle of treatment will be given on day one. Now, depending on the cancer, depending on the patient, those cycles, the duration will vary. So, let's suppose a doctor has prescribed 9 cycles of treatment. Okay, let's suppose 9 cycles of treatment there for one patient who has leukemia, for example. Okay, that means they will be given the drug for 9 different days over a period of time. Now, this period of time might be 20 days, 30 days, varies a lot. Okay, so for example, the first cycle was given on let's suppose day one. Okay, second cycle is given on day 5, थर्ड साइकिल इज गिवन ऑन डे 10. ऐसा 5 5 डेज के इंटरवल पे दे रहे, या 4 3 3 डेज के इंटरवल पे दे रहे. ओके, इन बिटवीन यू आर जस्ट मेंटेनिंग द पेशेंट्स कंडीशन, द गिविंग टाइम फॉर द बॉडी टू अडेप्ट टू द ड्रग. ठीक है, समटाइम्स what happens is these drugs will stay in your body for a very long period of time as well. That is also one of the reasons why duration of cycles will vary. ठीक है, this will go on for a long period of time. This is one cycle, ऐसा treatment देते. So one such problem that will occur in patients is nausea and vomiting that will go on for 1 to 2 days. All right, what you need to do is whenever you're giving anti-cancer drugs, you need to give a anti-emetic drug, especially in cancer, you use a drug called granisetron. Okay, it is similar to ondansetron in its action, but a little stronger, more indicated in cancer. So that is one. Then we have, you can also use ondansetron agar mild nausea vomiting hai. If severe nausea vomiting hai, then you give granisetron. Then we have hyperuricemia. Now, hyperuricemia specifically happens because that is uric acid levels will increase in blood because tumor cells are being killed. Whenever cells are dying, they will release a lot of uric acid. The byproduct of cell death will be uric acid. Okay, because of which uric acid levels in the blood will significantly increase. Then there is teratogenicity. Almost all cancer drugs are teratogenic, meaning they will cause death of the fetus because they are inherently cytotoxic. They will cause cell death. They also tend to be teratogenic. They will cause fetal death. Then the last one is carcinogenicity. Now, one other problem of anti-cancer drugs is that cytotoxic drugs themselves can cause secondary cancers. Okay, so for example, leukemias are common, right? Leukemia का जो treatment है, whenever you are treating leukemia, that treatment or the drugs that are used in leukemia, they can cause Hodgkin's lymphoma, they can cause lymph cancer. Okay, lymph duct and lymph nodules cancer. So the carcinogenicity is another problem with anti-neoplastic drugs, quite common. All right. So those are the common adverse effects. Now we'll get into the classification and the drugs that are used in cancer. Now, as such, there are six different classes you in cancer. Okay, and each of them generally tend to have subclasses in them. We'll try to make it as short as possible. All right. So first of all, coming to main classes, classification of antineoplastics. Okay, antineoplastics are drugs that are used in cancer. First class will be alkylating agents. Okay, alkylating agents. I'll first list down the main classes, then we'll get into each class. Then we have anti-metabolite drugs. Then we have natural products. Natural products. Then we have miscellaneous drugs. Fifth one will be hormones and their antagonists. Sixth one will be biological response modifiers. Okay, so these are the main classes. Now, first of all, coming to alkylating agents. Alkylating agents may mainly there's no subclasses in alkylating agents. There are a few drugs. You will have cyclophosphamide, ifosfamide, melphalan, chlorambucil, thiotepa, and cisplatin. We'll discuss some of the common ones. Okay. So first of all, coming to alkylating agents, common ones will include cyclophosphamide, ifosfamide. Be careful with the spellings. Okay. Melphalan, there is cisplatin, and chlorambucil. Okay. Now you will see some drugs that are common both in immunomodulators and in this. Okay, immunomodulators nahi hai, क्या बोलते हैं, immunosuppressants and this. Some of them are used interchangeably. You can use them as immunosuppressants and you can use them as cancer drugs as well. Now, the main mechanism of action through which alkylating agents work is they will exert a cytotoxic effect. They will cause cell death and they act as immunosuppressive agents and they act as radiomimetic agents. They will mimic the action of radiotherapy. All right. Specific mechanism of action is that these drugs will form highly reactive derivatives. So once you give, for example, let's suppose I All the drugs in alkylating agents will have the same mechanism of action. So um, the drug forms highly reactive derivatives, okay, byproducts or metabolites in a way. Okay, these derivatives, they will transfer alkyl group to various part of the cell. Okay, for example, let's suppose a patient has cancer in their kidneys. Okay, there is a tumor that is growing out of their kidneys like this. Okay, what this drug will do is it will alkylate both the cell as well as the DNA. Okay, this is the alkyl group. Ye drug, any of these alkylating agents, they are called alkylating agents because they will throw out or they will donate an alkyl group. The result is that whenever an alkyl group, whenever the drug is given, it is transferring alkyl groups, transfers alkyl group CH3, okay, uh, to various cells. Okay. Because of this, there is two actions. One thing is it will alkylate cell parts, so cell organelles, cell wall, all of that will get alkylated. Second is it alkylates DNA. Okay, so once the drug is getting inside your body, it is transferring to various cells of the body, specifically where the tumor is present, and it will start transferring alkyl groups. These highly reactive derivatives that you get from alkylating agents, they will start donating alkyl groups. These alkyl groups will attach to the parts of the cell, and it will attach to DNA of the cell. Now here our main target is the tumor cell itself, or the tumor itself, but let's suppose it is kidney cancer, it will also affect other cells of the kidney. Okay, normal cells of the kidney also will get affected. Because of which, what happens is, first of all, if it alkylates DNA, it will cause breakage of DNA strand. Breakage of DNA strand. Now, alkylating cell parts and breaking down DNA, both of which will result in improper metabolic reactions or stoppage of metabolic reactions, leading to cell death. Okay, so I'll repeat the whole thing once again. We have a drug, for example, if we take cyclophosphamide. Cyclophosphamide kya hota? This particular drug will get inside your body and it will get converted into aldophosphamide. It gets converted into an active form. Once that active form is getting inside your body, which is getting near the tumor cell, it will form very highly reactive derivatives which will start alkylating the cell. It will start donating alkyl group. This alkyl group will attach to different parts of the cell and it will invade inside the cell to alkylate DNA. Once it is alkylating DNA, it will break that DNA strand, and this results in improper metabolic reactions. Both alkylating the cell parts and breakage of DNA strand will lead to improper metabolic reaction and stoppage of metabolic reaction. If metabolic reactions do not occur in a cell, the cell will die. That is the mechanism of action of alkylating agents. It will lead to cytotoxicity. Right. Now, specifically coming to cyclophosphamide, once again, okay, let it be. Right. First of all, coming to cyclophosphamide. Now it gets converted to active form, which is aldophosphamide. Okay, this aldophosphamide will get into the cell and it will come near the tumor cell, start alkylating the agent, start alkylating the tumor cells, and in the process, it will also affect normal cells, wherein it will lead to cell death. Now you can give cyclophosphamide orally. There are some specific adverse effects. It makes a metabolite called acrolein. Okay, cyclophosphamide will have a metabolite. That metabolite is called acrolein. Now, acrolein can cause cystitis. Okay, it can cause bladder inflammation, urinary bladder inflammation, which can be prevented if you are able to give mesna. Okay, mesna बोल के एक drug रहता. This is specifically made for ifosfamide and cyclophosphamide. Whenever you give a patient cyclophosphamide and ifosfamide, there is a metabolite formed called acrolein. Acrolein can cause cystitis, because of which it will be harder for the patient to urinate. Okay, so as such, what you do is you will give mesna. By giving mesna, you are able to prevent cystitis to a certain extent or abate its effect. You can also perform irrigation, like bladder irrigation with acetylcysteine, or if you take a large amount of fluid with the drug, that can also prevent cystitis. Okay, cystitis is something very common with cyclophosphamide. Now, what mesna and acetylcysteine will do is they will inactivate toxic metabolites of uh, cyclophosphamide. So these will basically inhibit acrolein. Whenever you are giving cyclophosphamide, one byproduct is formed. That byproduct is causing an adverse effect. You want it to only cause antineoplastic effect. You do not want, or you want to suppress the side effects as much as possible, especially in this case where the side effects are very, very severe. Okay, if mesna is not given, the patient will have a lot of discomfort. So if you give mesna or acetylcysteine, it will inactivate these toxic metabolites of cyclophosphamide. Other than this, other than cystitis, cyclophosphamide and ifosfamide can both cause stomatitis. They can cause bone marrow depression. They can cause alopecia, vomiting, amenorrhea, and teratogenicity. Okay, almost all cancer drugs are teratogenic. But very few, one or two, can be given in pregnancy, but almost all of them are teratogenic. Cyclophosphamide can be used in lymphoma and leukemia. Lymphoma and leukemia. All right. You can also use it as an immunosuppressant in certain cases. Now, if we talk about cisplatin, cisplatin will have the same mechanism of action. It is also an alkylating agent. Cisplatin. Okay, it gets converted inside the body, and once it enters the cell, it will inhibit DNA synthesis, wherein it will cause cytotoxicity. Now, specific adverse effects related to cisplatin include ototoxicity. It can cause nephrotoxicity, peripheral nephropathy. So, nephrotoxicity can cause peripheral neuropathy. It can cause anemia and vomiting. Okay. Anaphylactoid reactions might occur. If you give cisplatin, the patient might have an allergic reaction. Keep adrenaline ready. Okay. It is specifically used for ovarian and testicular cancer. All right. You can also use it for head and neck cancers. Now, there is another drug called carboplatin. It is a congener of cisplatin, but it is less toxic. Okay. It will not cause as many side effects, and it is better tolerated as well. That is why carboplatin is used more nowadays. So, that is the first class, alkylating agents. Now, coming to the next class, have anti-metabolite drugs. Now, anti-metabolite drugs there are three subclasses, three main subclasses. Okay, first subclass will be folate antagonists. Second subclass will be purine antagonists. Third subclass will be pyrimidine antagonists. Pyrimidine antagonists. Okay, so folate antagonists में एक main drug आता है methotrexate. Methotrexate was another drug that was also used in immunosuppressants. We'll discuss about it here in a little bit more detail. Now, methotrexate as such works like sulfonamides. Okay, if you remember long ago, we had discussed about sulfonamides and we had discussed about trimethoprim specifically. This fellow will work like trimethoprim rather than sulfonamide specifically. What it will do is it will inhibit the conversion of dihydrofolate, dihydrofolate, once again, dihydrofolate to tetrahydrofolate. Okay. Specifically, what happens is whenever tetrahydrofolate formation is stopped, you will not have protein synthesis occurring. Tetrahydrofolate plays a very important role, not just in protein synthesis, it plays a role in DNA synthesis as well. Production of normal enzymes, production of purines, pyrimidines. Tetrahydrofolate is very important. So, if that does not occur, multiplication will stop. Okay, this drug will not exactly kill the cell, but it will stop the multiplication of the cell. Okay, this conversion is done by something called dihydrofolate reductase. Methotrexate will inhibit this enzyme. Okay, now in your cell, see, the doubt will come, trimethoprim is also doing the same function, so why can't trimethoprim be used here? Trimethoprim is a drug that will it will have less affinity to human cells. Okay, it will mainly affect the dihydrofolate of pathogens. It will affect dihydrofolate of bacteria rather than human dihydrofolate. Methotrexate is something that will affect human dihydrofolate. इसका मतलब ये भी है कि it will start affecting folic acid levels in your normal cells as well, because of which there will be severe toxicity because of methotrexate. Now normally whenever you are giving methotrexate to a patient, you have to supplement them with folinic acid. With folic acid, you have to supplement along with methotrexate so as to prevent methotrexate toxicity, because this will actively decrease the total amount of folic acid present in your body, or the production of folic acid will significantly decrease in your body. What we are trying to do is decrease the tetrahydrofolate levels only in tumor cells, not in normal cells. Okay, so whenever you are trying to give methotrexate, make sure that you supplement with folic acid. Now whenever methotrexate is getting inside the cell, it will stop the conversion of dihydrofolate to tetrahydrofolate. Tetrahydrofolate is responsible for production of nucleic acids, production of proteins, production of purines and pyrimidines, which is responsible for normal function of the cell. यहाँ पर by giving methotrexate, one specific function that is stopped is replication. All right, that tumor cell will not be able to replicate anymore. Here one of the main problems in cancer is that it is replicating uncontrollably. If you are able to give a drug that is stopping replication, you're essentially stopping cancer, at least for the duration where that drug is inside your body. All right. Now, methotrexate has several cytotoxic side effects, which include bone marrow depression. It will affect skin and gastrointestinal mucosa specifically. Okay, it will also affect the rapidly dividing cells in skin and gastric mucosa, but it will also cause skin and gastric mucosa side effects. All right. It has an anti-inflammatory property and immunosuppressive property, so you can use them in severe inflammatory conditions. You can also use it as a immunosuppressant. Specifically, in case of cancer, it is used for choriocarcinoma. Used for choriocarcinoma. So, cancer of the uterine lining. You can use it for acute leukemias. You can use it for breast cancer. You can use it for soft tissue carcinomas, rheumatoid arthritis, and psoriasis. Okay, rheumatoid arthritis and psoriasis, it will act as a immunosuppressant drug. All right, specific immunosuppressant drug. Now coming to folate antagonist में यही एक significant drug है. Coming to purine antagonists, purine antagonists में There is one main drug called 6-mercaptopurine. You have other drugs as well, azathioprine. There is thiaguanin, fludarabine, fludarabine. Okay, we'll discuss about 6-MP first. 6-mercaptopurine. Generally find it abbreviated as 6-MP. Okay, 1 second. 6-mercaptopurine. Now, this drug, once it gets inside the cell, it will get converted into an active metabolite. So, mechanism of action of the drug is that inside the cell. So, let's suppose this is the cell. Okay, 6-mercaptopurine, once it gets inside the cell, it will get converted into an active metabolite. Okay, in the presence of the cell, it will get converted into active metabolite, and this active metabolite gets incorporated into the DNA of the cell. Right. So the result is that it will cause breakage of DNA strand, one thing. Second is it will stop DNA synthesis from occurring. So it will do two things. Once it is getting incorporated into the DNA of your human cell, or specifically in the tumor cell, it will break DNA strands. Second thing it will do is inhibits DNA synthesis. Now, both of which will cause decrease in protein synthesis, or specifically protein synthesis is inhibited. If DNA strand is broken down and if DNA synthesis is not occurring, protein synthesis is inhibited. Eventually it will lead to death of the cell. Okay, if you are if you are able to break all the strands of DNA that is present inside the cell, it will eventually, it will correlate as you are breaking down the brain of the cell, ultimately leading to the death of the cell. But in any case, initially it will stop protein synthesis, where that cell will not be able to divide anymore and cell will not able to perform its normal function. Specifically यहाँ पर the cell is tumor cell. ठीक है, we are trying to target tumor cell, but invariably some of your normal cells will also start getting affected by these drugs. Okay, now you can use it in acute leukemia, you can use it in choriocarcinoma, you can also use them in solid tumors. Now, one important drug interaction that is associated with 6-mercaptopurine is that there is a drug called allopurinol. Okay, it's a uricosuric drug. Allopurinol. ठीक है, allopurinol क्या करता? There is one enzyme called xanthine oxidase. It will inhibit this enzyme so that total amount of uric acid present inside your blood is decreasing. It is a uricosuric drug given in gout. The problem is that whenever you give 6-mercaptopurine, 6-mercaptopurine depends on xanthine oxidase to get metabolized. Okay, so 6-MP is using xanthine oxidase to get metabolized. Now, if you give allopurinol along with 6-mercaptopurine, what ends up happening is, because xanthine oxidase level is decreasing, 6-mercaptopurine will stay in your body for a longer period of time. So, because let's suppose there is enzyme E, this is enzyme E that is responsible for drug 1, the metabolism of drug 1. You are giving some other drug 2, which is inhibiting enzyme. Which, because of this, what happens is metabolism of drug 1 will not occur. If metabolism of the drug is not occurring, it will not get excreted as quickly, meaning it will stay in your body for a longer period of time. As such, the action of the drug will also get prolonged. So what you need to do is, if you give 6-mercaptopurine with allopurinol or with any other xanthine oxidase inhibitor, this is allopurinol is a xanthine oxidase inhibitor. Okay, you will have to decrease the dosage of 6-mercaptopurine because it is getting metabolized slowly. It will stay in your body for a longer period of time, giving a higher chance of toxicity. So decrease the drug when you're giving with allopurinol. All right, we'll discuss about pyrimidine antagonists tomorrow.